Okay, first thing we're going to do is anesthetize the teeth. So watch that video on how to administer painless and profound local anesthesia for both maxillary and mandibular. So profound and painless local anesthesia, very important. So here's the intraligamental, even around the wisdom tooth. So we're starting with the lower left impacted wisdom tooth. So it looks like there's some space on the distal of the wisdom tooth, and the roots are only 50% formed. So I think there's a very good chance I'll be able to elevate this tooth out of the socket without removing any bone or sectioning the tooth. When I see this space, that means I've got a space to elevate the tooth into. Now, if it was a fully formed wisdom tooth, the roots were completely formed, and the patient was older, this space probably wouldn't be here. That's the follicular sac. And so you probably would have to remove either part of the tooth on the distal or some of the bone on the distal to create a space to elevate the tooth into. I don't think I'm going to have to do that with this tooth, but always look at it before I extract the tooth and picture in my mind what I think I'm going to have to do. This is a critical cut right here up the ramus of the mandible to the distal buccal of the second molar. It's a full thickness cut. Then you cut from that cut to the distal lingual of the second molar. Don't cut onto the lingual, just cut to the distal lingual, creating this wedge. Then you cut distal to the second molar so that you can elevate that wedge and remove that tissue so you can visualize the wisdom tooth. It also makes it easier to connect the flaps when you're suturing. So I'm using the scissors to cut up the ramus of the mandible, subperiosteal. So you want to be able to reflect enough flap that you've got access to the tooth. So now this is a electric handpiece, lots of water, with a moderate round burr. It's probably about a number 6 round burr, long shank. And I'm removing the bone on the coronal part of the tooth. So I can visualize the tooth. Now I'm placing a 301 elevator on the mesial of that tooth. You can think about how important it is to visualize what you're going to do before you do it. I'm thinking I can elevate that tooth without removing any bone or having to section the tooth. Sometimes you've got to slide a periosteal elevator between the second molar and the wisdom tooth if there's not much space. But since this was a younger person, there was a follicular sac around the tooth, the roots weren't completely formed, I felt like I could elevate the tooth and I can go straight to the 301. Now you see how I've got my finger in here to protect the airway. You want to either place your finger or 2x2 gauze on the lingual to protect the airway. You do not want the patient to aspirate that tooth. I'm cutting up the ramus of the mandible. That's a full thickness cut through the periosteum so you can elevate the flap. And you don't want the tooth to tear the tissue when it comes out. You want the cut to be made so it comes out of an opening. It heals better. So I'm elevating that tooth into that space. There it is. Hello, this video is a small portion of a complete comprehensive video. If you'd like to see this complete comprehensive case and many other complete comprehensive cases, click on the link in the description below. Now you know, especially since this is a younger person, you're going to have a follicular sac, and you always want to remove the follicular sac with the rongeers. Then I'm going to pack the socket with this material and that Surgicel. Now what does the packing do? The reason I've not had a dry socket in over 40 years of teeth extraction and wisdom teeth extraction is because I packed the socket. What is a dry socket? A dry socket means the patient has lost all or part of the blood clot in the socket. There are nerve endings in the bone, and if the blood clot acts to insulate the nerve endings. If you lose the blood clot, the nerve endings are exposed. So if you pack the socket, the packing material serves as a matrix in the socket to contain that blood clot for a week, because it takes 7 days for the connective tissue lining to form over the nerve endings in the bone. So that's the key period of time, 7 days. When somebody gets a dry socket, when do they get a dry socket? Usually after 2 to 4 days. The packing material acts as a matrix and contains the blood clot, so the nerve endings aren't exposed until the connective tissue lining forms in 7 days. So I'm suturing the mandibular wisdom tooth. I'll use 3/0 plain gut, and I'll put 2 to 3 suture after I've extracted a mandibular wisdom tooth. I normally just place 1 suture when I've extracted a impacted maxillary wisdom tooth. So when you suture, you want to first go away from you, 1, 2, pull. Or if it's 4/0 gut, I'll go 1, 2, 3. Sometimes even with 3/0, I'll go 1, 2, 3 away and pull, then 1 toward me, pull, then another one away, then pull. 1, 2, 3. So I'm doing 3 on this one. Then I'm going to do 1 toward me and pull, and 1 away, then pull. The reason you sometimes start with 3, because sometimes when you just do 2 and you pull, it'll loosen before you get to the second one towards you. So the 3, it stays tight. And I want about 2 to 3 millimeters of tag when the suture's cut. You don't want to cut it right at the knot. You want 2 to 3 millimeters so it doesn't come untied. So here's the maxillary left wisdom tooth, and let's skull drill this one. This is softer bone. The maxillary posterior is the softest bone in the mouth. We see the sinus up here. So since this is soft bone, since it's a 17-year-old person, it's got a follicular sac around the wisdom tooth, I'm thinking that I can elevate this tooth distally and place a periosteo elevator in this tight space here and get it going, and then place the 301 elevator and elevate it, then the curved elevator, and just out it comes. So you're going to make a vertical cut through the attached gingiva on the distal facial of the second molar. Then you're going to cut around the second molar to the first molar. Then you're going to cut on the distal, direct distal of the second molar, so you can reflect that flap. Remember, you want the tooth to elevate through an incision. You don't want it to tear the tissue. You want to make enough of an incision that it can elevate through that opening, through that reflected tissue. So this is a periosteal elevator, and it's such a tight space between the wisdom tooth and the second molar that I'm using that periosteal elevator just to get it moving. I'm coming back with the 301 elevator. See, I've got my 2x2 in the mouth to protect the airway. Back with the periosteal elevator just to get it going, so I've got access with the 301. Then I'm using the crossbar, the Potts crossbar elevator. There's one that goes this way and one that goes the other way. So I'm using the one that goes the other way, and it just wraps around the mesial of that wisdom tooth and comes right out. Be sure you're protecting the airway. There's the mandibular, and the maxillary. Then you're going to remove the follicular sac. And why do you remove the follicular sac? The follicular sac can form into a dentigerous cyst, which could form into an ameloblastoma. Now, I've never seen that happen. I've seen ameloblastomas, I've seen dentigerous cysts, but the literature says the material of the follicular sac can form into a dentigerous cyst, which could then form into an ameloblastoma, which causes the mandibular bone to degenerate. So you just, for good form, you want to remove the follicular sac after you extract an impacted tooth. So I'm just using here's 1, 2, 3 away, pull, and you've got to keep it pretty taut or it'll get it'll have a loop in it. Then 1 toward me, then 1 away. You pull each one tight. So 3 away, 1 toward me, 1 away. Now I'm anesthetizing the right side with a infiltration for the maxillary right wisdom tooth and mandibular block. for the mandibular right wisdom tooth. Here's the mandibular right wisdom tooth. So again, the same cut up the ramus of the mandible to the distal buccal of the second molar. It's a full thickness flap. That's the dental minute. These techniques work, and they work every time.
It's time. It is time to take your dentistry practice to the next level, and you know it. You just haven't known how to do it until right now. That's where dentistrymasterclasses.com steps in. At dentistrymasterclasses.com, Dr. Cutbirth is offering you his greatest work and his best cases. Here's everything that you're going to get when you subscribe to dentistrymasterclasses.com. Incredible comprehensive cases not seen in Dental Minute videos, an organized library of all the Dental Minute videos, and Dentistry Masterclasses comprehensive cases for study and reference. And you're going to get before and after photos of Dr. Cutbirth's fantastic restored work. So, great deal. $40, that is it. For $40, you're gonna get all of this. So go right now to dentistrymasterclasses.com and subscribe today and change your life, change your practice.